Professor Syed Ziaur Rahman.
Syed sir is there already. Syed sir, you are not audible.
I finished myself. This is about pharmacology now.
Syed Ziaur Rahman. Syed Ziaur Rahman. Syed Ziaur Rahman, sir. अंजुम चुगताई सर हैं connected.
In the meantime, I'd like to request Professor Himanshu Reddy, sir, if you are there, maybe you can tell us a little bit about this drug.
Yeah, sure. Thank you very much.
Can you hear me now? Sorry, there was some problem in the net. Can you hear me now, Dr. Tabish?
Yes, now you are audible.
Dr. Tabish, can you?
Syed sir, muted again. You have to unmute. Yes, yes.
Yeah. Okay. Can you hear?
Yes. Now
Yes.
All right. Thank you so much. Sorry for this technical hitch. So I was telling that when we were discussing about this panel discussion, I was asked to throw some light on the pharmacology part of the mucormycosis. So you know that this amphotericin B is the drug of choice in mucormycosis, and this is a polyene antibiotic, which is antimycotic also. It is derived from Streptomyces nodosus. And it's very important from pharmacological point of view to know the mechanism of action of this drug. So what happens is this amphotericin B binds to ergosterol of the cell membrane of the fungus. And this ergosterol keeps the membrane stable. The binding of this amphotericin B to ergosterol leads to the formation of pores and the channels. And these pores then leads to the exclusion of the micronutrients, including the potassium ions and ultimately cell death. तो इसको ऐसा समझा जाए जैसे कि फंगस सेल एक गुब्बारा है जो कि एक फूला हुआ है और उसमें जो है गैस है या पानी है और उसमें एक छेद कर दिया जाए तो उसमें से धीरे धीरे से हवा निकलती जाएगी और गुब्बारा जो है वो डिफ्लेट हो जाएगा. इसी तरह से सेल जो है वो डिफ्लेट हो जाता है जिस तरह से इसके माइक्रोन्यूट्रिएंट्स इसके निकल जाते हैं. So in addition to this formation of pores and channels, it is also observed that amphotericin B weakens the cell membrane. As you can see in the diagram, that it weakens the cell membrane as well as causes the oxidative damage to the cell. And this oxidative damage may lead to oxidative stress to the whole cell, and because of this oxidative stress there is a membrane damage, DNA damage, protein damage, and also the mitochondrial damage. And you all know that mitochondria is the powerhouse, and if we damage the mitochondria, so this will lead to the loss of the metabolic activity. यानी इस तरह समझिए कि ये जो एम्फोटेरिसिन बी है इस तरह से काम करता है कि पूरा एक सेल की एक तरीके से पूरी हवा ही निकाल देता है. So this is the main mechanism of action of this drug, amphotericin B. And apart from, and this amphotericin B is basically conventional form is amphotericin B deoxycholate, which can be given intravenously and intrathecal, especially in the rhinocerebral mucormycosis, the intrathecal route. And in addition to this conventional drug, we have three lipid associated formulations: amphotericin B complex, liposomal amphotericin B, and amphotericin B colloidal dispersion, as you can see in the diagram also. And these are given in different doses, obviously, as you can also imagine that these three lipid associated formulations are better and better than the conventional. And there is not much difference in the mechanism of action of these lipid associated drugs, except the difference in the pharmacokinetics. So you can say that all these drugs has either conventional or lipid associated formulation, all these drugs have same efficacy. There is no microbiological outcome change also, but due to the change in the pharmacokinetics, these lipid associated drugs, they may have slow release preparation, less tissue deposition, less lipid solubility, and requires a low dose. And because of this low dose, it may also cause the renal clearance is also very low in these drugs. And you can also see that, as I said, these drugs are given intravenously, and because of this intravenous administration, it may cause infusion-related reaction, which may be like high fever, the anorexia, nausea, vomiting, headache, and also causes nephrotoxicity, which is that basically the damage of the tubular membrane. Uh, and also, if it is given intravenously, it may cause phlebitis, anemia, and hemorrhagic gastroenteritis, LFT changes, ventricular fibrillation, cardiac arrest. And if it is given intrathecally, then it may cause seizures and arachnoiditis. So if you comment that why there is renal damage with these conventional drugs and the lipid-associated drugs, it's because, as you know, that this drug has affinity with ergosterol of the fungal cell membrane. Sometimes, or it may affect the sterol of the human cell also, particularly of the renal tubule. And if it affects the renal tubule or the sterol of the kidney, then like the fungal cell, it may also lead to hypokalemia, hypomagnesemia, and loss of the magnesium and the potassium ions, and also the urinary cast and hematuria. So this all is a part of the nephrotoxicity. So there is a region of this nephrotoxicity because it gets accumulated in the kidney, especially the renal tubular cells. That's why we observe such type of adverse effects. Then we were also discussing in the before this panel discussion that why these lipid preparations are preferred. So the reason is very simple, that they are more specific to ergosterol of the fungal cell. They are slowly released formulation, and they are very target specific. There is a less chance of toxicity and nephrotoxicity. Then if you see these toxicities and nephrotoxicity is very common in the adult population, but very less safety data is available in relation to children. And in our global international area monitoring database, which is maintained at Uppsala, Sweden, it was found that amphotericin B as compared to the adult, it causes less nephrotoxicity in children. But in children, there may be an effect in the liver because it is seen that there is deranged transaminases in the children population. So it may cause hepatotoxicity in children rather than hepatotoxicity. In addition to amphotericin B formulations, we have other drugs for mucormycosis, which comes under the category of triazoles. So there are many drugs which comes under antifungal group of classification, but triazole, in comparison to imidazole, they have some affinity with the control of ergosterol, because this triazole has different mechanism of action. Amphotericin B weakens the cell membrane and makes the pore, while this triazole basically inhibits the formation of the ergosterol. So there is no formation of ergosterol, and so the drugs which comes under this triazole are posaconazole, which comes in the market in the delayed release tablet form, and isovuconazole, which is also the triazole group. And then somebody was asking that what is the role of the methylene blue? So methylene blue basically helps in the prevention and it's oxidizing agent like amphotericin B, which causes the oxidative stress. So this also leads to the oxidative stress and leads to the death of the cell. So in the prevention, it may be used. But remember, one very important thing is we should not combine amphotericin B with these azoles, because these two have different mechanism of action. If we inhibit the synthesis of ergosterol by azole, then there will be no ergosterol available for the action of amphotericin B. Amphotericin B basically binds with ergosterol, and if we don't have ergosterol, then there is no role of amphotericin B. So these combination should not be given altogether. It's an antagonistic effect. So pharmacological point of view, they have different mechanism of action. So I think this is from my part. If there is some question, I'll be happy to answer. Thank you so much.
Okay, now thank you very much, sir. Actually, since we are running very short of time, so what I can inform you from your talk is that we have to be cautious while using amphotericin in renal patients, and when going for amphotericin B formulations, go for lipid preparations, and while administering the drug, we should watch for the infusion reactions, right? Okay, now we'll quickly switch over to our next panelist, that is